Okay, good afternoon, everybody. Thank you so much for joining us today for this webinar called Health Disparities, Breastfeeding's Role in Closing the Gap, Moving Away from Lack. So thank you to Dr. Camille Clare for joining us today. We're privileged actually to have you with us today. In our panel is also Patty Guzman and Paula Loeb, and they are lactation counselors here at Montefiore Nyack Hospital. Also, thank you so much to all people who register. We are overwhelmed by how well this topic is received. We have 60 people registered for this webinar, so we're very happy about that. So we have an hour for this webinar. It will run from 12 to 1 p.m. and the webinar is being recorded for later viewing. So let's start. Let me introduce our guest speaker. Dr. Camille Clare is an associate professor of obstetrics and gynecology at New York Medical College and attending physician at Metropolitan Hospital in Manhattan. She received her medical degree from Albert Einstein College of Medicine and completed her obstetrics and gynecology residence at the State University of New York at Buffalo. She obtained a Master's of Public Health in Health Policy and Management at New York Medical College. Dr. Clare received certification as Physician Executive from the Certifying Commission on Medical Management in 2012. Her clinical research interests include adolescent contraception and family planning, postpartum depression, patient safety, medical education, and healthcare disparities. She serves as the Director of Resident Research in her department. Presently, she is the Associate Dean of Diversity and Inclusion at the New York Medical College School of Medicine. Dr. Clare has received multiple teaching and mentorship and service awards. In fact, this year, she received the American College of Obstetricians and Gynecologists Mentor of the Year Award. Dr. Clare is an active member of the Obstetrics and Gynecology section of National Medical Association, which is the largest and oldest organization of the African American physicians in the United States. She serves on the NMA Breastfeeding Alliance Task Force, presenting on disparities in breastfeeding rates in African American women. She holds many other leadership positions in the NMA and American College of Obstetricians and Gynecologists, including the ACOG District 2 Vice Chair-elect. So welcome, Dr. Clare. We're so happy that you are with us today. And just as a reminder for all of our attendees, there is a chat box and we have a Q&A box. So please, as Dr. Clare is presenting, just write your questions in the chat and Q&A box, and we will be very happy to share these questions and get you all the answers that you want. So, Dr. Clare, the podium, virtual podium, I should say, is all yours.
Thank you so much, Sandra, for that generous introduction, and welcome to all the participants. Thanks to Ariel and colleagues for the invitation to speak to you about something which I'm passionate about. So we'll get started for the sake of time. Hold on. So I have no disclosures relevant to this presentation. However, I am a lactivist, which is basically an activist in the area of breastfeeding, a term that I've come to learn. So our goals today, we're going to be talking about the social determinants of health and how race and health disparities impact that. We'll talk a little bit about breastfeeding rates, specifically in African American and other underserved groups. Hopefully talk about some solutions along with my colleagues on the phone today or the webinar today, and talk about some of the work that we've done with the National Medical Association to address some of these issues. But hopefully this will be interactive, and Sandra will help me answer any questions in the chat or in the Q&A box. So feel free to ask me anything throughout the presentation. So when I probably first gave this presentation, I focused a lot on the concept of disparities. But in more recent times, I really decided to sort of change the narrative so that we're kind of moving away from what is missing and what populations lack, away from that concept to what is inequity. So to focus more on the structural and institutional explanations for these differences in breastfeeding rates in different groups. We know that the privilege of breastfeeding has been created by oppression. And as you've heard, I come to you with an equity lens. So hopefully that will be illustrated in this talk. This really is an era of time of reclaiming the human rights, including that right to breastfeed, as well as really focus on the lived experiences and the community-based experiences of the patients and the clients that we serve. So it's not just an ivory tower approach where one group or one, set of people are better than others, but moving away from that to focus on the structural issues. So we know that there's multi-generational support for breastfeeding, even for those who could not or did not breast and chest feed. So for the majority of the talk, I'm going to be using the term breastfeed, but we know that that is a very gendered language. And so there is engendered language to focus on chest feeding or providing human milk for one's baby, just to be aware of that, even though throughout this presentation, I may be using the gendered terms of breastfeeding. So if we think about the structural determinants of health, we know that those are the conditions in which environments or the environments that people are born, they live, they work, they play, which affects their ability to achieve health. Those conditions may be social, economic, physical, and they vary in the different environments and the settings in which patients or clients live, and that's referred to the place. And so we know that there are resources that can enhance someone's quality of life, which has a significant impact on their health outcomes. And those include such things as safe, affordable housing, access to education, public safety, the availability of healthy foods or not living in food insecure areas, having local emergency services available to you, as well as environments that are free from toxins that may be detrimental to your health. So if we think about those concepts and how they relate to breastfeeding, on a societal level, those issues include breastfeeding legislation and policy on the governmental level, having paid maternity leave, being uninsured or underinsured, what is the cultural attitudes about breasts, and what are societal norms about bottle feeding in particular. On a community level, that includes having a lack of peer-based support groups such as La Leche League, Mocha Moms, culturally sensitive or culturally humility groups that can impact how someone feels about breastfeeding in their community. It also includes cultural attitudes about formula or breast milk adequacy, as well as formula companies, hospitals, the WHO, for example, and how they talk to us about breastfeeding policies. On an organizational level, what happens at the level of the hospital? What is the influence and authority of physicians? What may be workplace barriers that prevent patients from breastfeeding at their workplace? In addition, on an interpersonal level, what are is there intergenerational support, which may be lacking on an individual level? What is the role of someone's friends who may have not enough knowledge or may have misinformed knowledge about breastfeeding? What is the attitude of the public in terms of breastfeeding or nursing in public, which has been perceived to have general disapproval? Is there a lack of support from a patient's or a client's partner or the baby's father? In addition, is there a lack of discussion by healthcare providers about the benefits of breastfeeding? On an individual level, are there personal obstacles such as pain, discouragement? Is there a particular worry about the baby that may influence someone's ability to breastfeed? Also, may there be a lack of knowledge about where to seek information about breastfeeding, or are there certain cultural attitudes about breasts in particular? So we know that African American women in particular bear a huge disproportionate share of disease. This is an old data point, but morbidity, mortality, it's been well publicized in the lay press. and including increasing disability and injury compared to other groups. This is a fairly old slide dating back to 2007, but it's pretty much the same right now, where non-Hispanic Black women have increased levels of maternal mortality and this is the percent of deaths or numbers of deaths per 100,000 live births, and this has not really changed in the last 10 to 12 years, so this is pretty much the same. For infants, infant mortality rates are equally disproportionate in African American women in particular, or babies in particular. You can see that compared to any other groups, African American babies are more likely to pass away compared to any other groups. And this is data that was from 2000 to 2009. And if we look at the percent of babies that have ever breastfed compared to those who've been breastfed at 6 months, 12 months, or exclusively breastfed at 6 months, you can see that for African American women, these rates have been disproportionately low for any of these categories of breastfeeding over time. And this is a slide that talks about the percent of infants who are ever breastfed based on their race and ethnicity. And you can see this is from the early 1990s to 2006 or so, again, for non-Hispanic Black women, and sorry, that B, this is an old slide, that B should be a capital B as opposed to a small b, they have had the lowest rates of infants that have ever been breastfed based on race and ethnicity. This graph illustrates how many infants were breastfed, percentage of infants that were breastfed based on race and ethnicity, and, and what's called a poverty income ratio. And this is an index that has divided family income based on a certain poverty threshold that's specific based on a size of a family. So low income was considered to be this PIR of less than 1.85, compared to high income was greater than 1.85. And you can see again, African American women in particular, whether they're low income or high income, they had lower rates of the percentage of infants that were breastfed, whether they were low income or high income. Mexican Americans, you can see there was really no difference, and they had high rates of percentage of infants that were breastfed, whether they were low income or high income. And again, this is looking at based on maternal age and race and ethnicity. So you can see that for women that are less than 20 years of age, for all groups, they had low percentages of infants that were breastfed. So this may be a population in particular that we need to focus on most of our energy. And you can see again for Mexican American women, again of all ages from less than 20 all the way to over 30, they also had high rates of breastfeeding compared to any other group. So this is a slide from the Department of Health, the New York State Department of Health, again, looking at the percentages of infants that were breastfed in the hospital. So many of us work in the hospital setting, so this is something to think about. And this is from 2011 to 2015. And you can see that for infants that received breast milk in the hospital over this period of time, any breast milk in particular, those rates were pretty high in the hospital level. The number of infants that were supplemented with formula has been decreasing over time, and that is good. And the percentage of babies that were exclusively breastfed has also increased over time, hovering about 45%. So that's very good. But obviously there's room for improvement. Again, this is another way of describing that. Again, in 2015, the percentage of infants that were breastfed in the hospital has been increasing, any breastfeeding about 88% or so. And again, similar numbers as what we saw in the previous slide. And then this is looking at the percentage of infants that were exclusively breastfed in the hospital, again, based on maternal characteristics, so race and ethnicity, education of the mom, as well as the insurance coverage or the payment for the delivery for that individual mom. So you can see here again that African American women in particular had the lowest rates of exclusive breastfeeding in the hospital setting, about 33% or so. Moms that had more than a high school education were more likely to exclusively breastfeed in the hospital, and moms that had other rates of insurance coverage other than Medicaid as well had about 55% of exclusive breastfeeding rates in the hospital. If we look at the infants that were enrolled based on enrolled in WIC by race and ethnicity, this is 2016, again, DOH data. You can see that again for for many of the groups, pretty much all the groups had high enrollment in WIC based on race and ethnicity. And you can see they compared that to the breastfeeding initiation. So those rates were pretty high, but you can see over time, breastfeeding at 6 months versus breastfeeding at 12 months really decreased for every group that's illustrated here in this slide. So this is a slide, again, looking at infant mortality rates per 1,000 live births based on race and ethnicity in New York State. In the, up to 2015. And you can see, again, for African-American infants, they had the highest rates of deaths. You can see for American Indian and Alaska Natives, they had low rates in 2010, but those rates increased significantly from 2010 to 2013, approaching equal levels to African-American infants, and those have gone down again. So again, these are populations that we really need to focus on in looking at what we're doing. Again, this is more recent data looking at maternal mortality that I talked to you about earlier. In New York State data, again, 2008 to 2015, we can see that those rates are going in the wrong direction and to be very, very high rates, specifically for African-American women. So again, this is a similar slide as before. The New York State infants that were breastfed in the hospital based on race and ethnicity. For Caucasian babies in particular, those rates were about 56.1% compared to about in the 30% range for any other groups. And that was exclusive breastfeeding is what I was talking about right there. Again, this is very similar data, looking at very similar data, as I mentioned before, of the New York State infants that were exclusively breastfed in the hospital setting. So what are we doing to impact that? There's always room for improvement. You can see for white mothers in particular, about 56% or so, as well as for Native American mothers, 52%, and for any other groups, about 35% exclusive breastfeeding rates in the hospital. And this is very similar data again. So I apologize if we're going a little bit fast over the data points, but we have a lot to cover, and I know I wanted to leave enough time for discussion. So this is looking at ACOG data that put together in a toolkit several years ago, looking at how we were doing compared to the Healthy People 2020 target rates. We're here now in 2020, and we can see that only 50% or so were breastfeeding at 6 months compared to 27% at 12 months, which was way below the target rates in the Healthy People 2020 goals. And what were those targets that we should have attained? So we were supposed to increase the proportion of infants that were ever breastfed to about 82%, who were breastfed at 6 months, about 60%, who were breastfed at 1 year, about 34%, those that were exclusively breastfed through 3 months, about 46%, and those who were exclusively breastfed through 6 months, about 25%. Other goals include how can employers have more improved on-site lactation support, about 38%, and how can we reduce the proportion of infants that were breastfed who received any supplementation in the first 2 days of life. The goal was about 14%. And the other goal was to increase the proportion of live births that occurred in facilities that really recommended care for lactating mothers and their babies, including lactation support, lactation counselors, being a baby-friendly hospital, et cetera. That goal was about 8%. So what about 2030? That's our goal that we need to attain. There's really only one breastfeeding objective in the Healthy People 2030 proposal, and that says that for maternal, infant, child health, we should increase the proportion of infants that are breastfed exclusively through 6 months. So what are some factors that negatively impacts breastfeeding? So some of the factors include being African American, being poor, mothers that are younger, as well as being single or having less support. So if we look at breastfeeding in underserved women in particular, and this is data that was proposed from the ACOG committee opinion in 2013, we have a committee on health care for underserved women, and they found that disproportionately underserved women were less likely to, or more likely rather, to experience adverse health outcomes that may improve if they were able to breastfeed. They may face unique barriers and have low rates of initiation as well as continuation of breastfeeding. There are disparities or inequities, as I mentioned before, that exist with including breastfeeding initiation, specifically among African American women, as well as women who are receiving WIC. And these rates in terms of breastfeeding initiation is about 58% in African American women and 66% among those who are receiving WIC. Age disparities, as we've seen in the slides earlier, also exist, so that there are initiation rates of about 53% in women that are younger than age 20, compared to those initiation rates of almost 70% of women between 20 and almost 30, and over 78% in women, almost 78% in women that are over 30. Also, as we've seen in earlier slides, women with a high school diploma or less are also less likely to breastfeed. They may not be aware of the specific benefits of breastfeeding, as well as they may be less familiar with techniques for successful breastfeeding. Poor family and social supports has been shown to be a barrier, as well as adolescents in particular may have their own misconceptions about breastfeeding. So for over 30 years, African American women really have had the lowest rates of breastfeeding, compared to the gold standard of exclusive breastfeeding for about 6 months. And that rate, again, is only 20% compared to about 40% among whites. Where is this coming from? Cultural hang-ups have really contributed to these differences. Our communities in particular have been targeted, high targets of aggressive marketing campaigns by formula companies, which really started back in the 1930s and 1940s, where formula feeding was seen as the choice of the elite and really for the sophisticated women in society who are of any racial group, specifically white women as well as Black women. However, when white women in particular headed towards infant formula, that was followed by Black women. But when white women reversed that course, led by any celebrity benefits or celebrity endorsement of blackfeeding, the idea of good mothering, Black women in particular didn't necessarily buy in. Early images really showed Black women that were semi-naked from Africa, called this National Geographic factor, which many women in the United States, Black women in particular, didn't really go along with or feel that they could relate to those early images. However, this is more than just breastfeeding alone. The practice or lack of practice can really be linked to someone feeling empowered or not empowered, or it can be related to feelings of self-worth, as well as being connected to the healthcare community. So all those things are really important when we're counseling Black women in particular about breastfeeding. Several of these data points, as I said, we mentioned, but more recent data has shown, and this is from the U.S. National Immunization Survey. Again, about 66% of African American women have initiated breastfeeding in 2012, compared to about 83% or so in both Caucasian women as well as Hispanic women. Again, these gaps in breastfeeding has continued even up to 6 months, where only a third of African American mothers are still breastfeeding, compared to about 50% or so of Caucasian mothers as well as Hispanic mothers. So this was a study that was conducted, a community-based participatory research study that was conducted in several areas, including Baltimore, Washington, D.C., and Illinois. They looked at about 1,600 mothers. This was an NIH study, and the goal was to look at what factors contributed to these differences in healthcare or health for mothers and their infants. So from the community level, the family level, the individual level. So again, they looked at mothers from 2008 to 2010 that were low socioeconomic status based on their postpartum stay. They interviewed them as well as followed them up for the period of time of 1 month and 6 months postpartum. So they found that Spanish-speaking Hispanic mothers were most likely to initiate breastfeeding, about 91%. They had a high intent to breastfeed, again, about 92%, and were likely to maintain breastfeeding for about a mean duration of almost 17 weeks. And this was followed by English-speaking Hispanic mothers, which had an initiation goal of 90, or initiation of 90%, intent of 88%, and a mean duration of about 10 weeks period of time. If we compare this to Caucasian mothers in this study, the initiation rate, again, almost 80%, intent rate 77%, and a mean duration of breastfeeding about 16 weeks. And you compare this to African American mothers, which basically had an initiation rate of 61%, an intent rate of 57%, and a mean duration of 6.4 weeks. So what are the demographic factors related to these differences between specifically African American and Caucasian mothers in terms of intent and initiation rates? What were some of these characteristics, as well as in-hospital formula feeding patterns that explained how long these mothers breastfed for, as well as what were some family breastfeeding history and other demographic factors that influenced, in particular, the higher rates of breastfeeding specifically found in Hispanic mothers. That group in particular had intergenerational experiences with breastfeeding, as well as intergenerational support for breastfeeding. So all those factors played a role. What about the role of racism, especially in the racialized world that we're living in now, which is not new? The role of racism is really, really important in terms of how women are able to handle their thoughts about breastfeeding. There is internalized racism where mothers may feel, again, a lack of self-worth or confidence. There may be such factors as an allostatic load, which basically is how someone from a pathophysiological perspective can really handle some of the stressors that they experience. So studies have found that specifically for African Americans that may be under chronic stress, they may experience some of the poor health outcomes at much earlier ages, such as heart disease, because they're experiencing chronic stress at earlier ages. There may be institutionalized racism. So what is happening at the hospital level? Is there poor hospital practices that are influencing the rates of breastfeeding that mothers are doing? We can't forget the cultural taboos that have been associated with breastfeeding, which is illustrated in this picture. And we'll take a few minutes to talk about that right now. This is a study that was conducted by Ms. Devane Johnson, obtaining her doctoral degree from UNC Chapel Hill. She looked at 39 women in focus groups, and these women ranged up to age 89 years of age. She looked at, she basically found that breastfeeding was a topic that couldn't be addressed in these families that she studied. Women were told in their families that you can't do that in my house, breastfeeding is nasty. You don't talk about boobies, breasts are seen as sexual and not as functional. We know, again, about the history of African American women and breastfeeding during the time of slavery. We know that older Black women, sorry, the B should be capitalized there, had wanted to disassociate themselves from their past history, again, of slavery and being wet nurses. Their images of being known as a mammy. This is a cultural memory that has really been passed down from generation to generation, even including younger women. We know that enslaved babies were more likely to die during slavery because they weren't breastfed by their mothers. Instead, they were fed watered down concoctions of water and cow's milk. However, the children's mothers' breast milk were given to the white children under their care. And there was also several issues related to class. So we have to really remember this when we're currently counseling women, that this generational memory is really ingrained from generation to generation. And this is depicted here in some of these future slides. So in this study by Dr. Dunaway, she looked at, again, how slavery and emancipation impacted the rates of breastfeeding. And again, she also found that wet nursing really claimed the benefits of breastfeeding for the offspring of the slave masters and limited that for those that were enslaved. So again, we saw that for white offspring, they really felt the nurturing and affection that might have been allocated to enslaved mothers' children because they were separated from their children. Also, slave owners very often forced Black mothers to stop breastfeeding early so that they can continue to breed and provide more property and capital for those who were enslaving them. But what can we do in terms, if we switch gears a little bit, to talk about breastfeeding's role in addressing some of the health outcomes that we know to be the case? We know that several associations have been emerged in terms of levels of lower stress levels, fewer episodes of depression. Breastfeeding has been associated with changes in the brain to really affect things such as increased IQ in children, reducing stress, improvement in mental health, as well as we know about the bonds between the mother-infant dyad, which is really, really important. Several of you may be familiar with the benefits of breastfeeding slide, and this is an ACOG produced infographic that really shows for both the mother and the infant. Many of us are very familiar with these benefits for mothers, including reduced rates of diabetes, high blood pressure, heart disease, as well as reducing rates of breast cancer and ovarian cancer. We know for the baby, as mentioned, improved digestion, containing antibodies that have helped with immunity, as well as reducing rates of sudden infant death syndrome, etc. So we've talked a lot about the problems, but what can we do to address some of these differences on a policy level? Any programmatic changes we can do? How can we work with our peers and the peers of moms that are breastfeeding, as well as partners of those who are breastfeeding? And we'll talk about at least what some of the things that I've been involved with in the National Medical Association. So as mentioned, the NMA does have a Breastfeeding Alliance. This was a multi-phase approach to address some of these reasons for these disparities in the breastfeeding, in breastfeeding African American women in particular, mainly from the physician level to address why these rates are so low in spite of any cultural specific interventions that might have already occurred, as well as how can we develop methodologies to really continue to reduce some of these inequities. As mentioned, the National Medical Association is the largest and the oldest organization of African American physicians. We celebrated our 125th anniversary this year. The NMA was founded in 1895 when Black physicians were not allowed to join the American Medical Association, as well as to admit patients to hospitals. So that's the reason why the NMA was founded. So what has the Breast Alliance done? So the purpose of this alliance was really to kind of gather, advocate, generate information in many different forums. So lecture presentations at historically Black colleges and universities, where a lot of the underserved patients are being served. How can we really best explain and delineate what are those demotivators for breastfeeding support, specifically among physicians and the patients they serve, looking at sort of evidence-based approaches. This is a multi-specialty group of physicians, so not only OBGYNs, but pediatricians, internal medicine physicians, family physicians. And how can we look at, again, culturally competent, structurally competent interventions to address these issues, as well as highlight education and research and improved communication. This was a grant-supported effort from the Kellogg Foundation from 2013 to 2016. We created a breastfeeding survey, which we piloted in 2013 at one of our conventions. We held several symposiums and educational efforts throughout multiple communities, including radio interviews during Breastfeeding Week, several DVDs and posters that were sent to our members to have in their offices. I've also presented as member of the New York Statewide Breastfeeding Coalition back in 2016 to talk about some of our efforts. We also created at the time a breastfeeding microsite within the National Medical Association website. We also created a breastfeeding newsletter. As I mentioned, multiple speaker presentations at several of our conventions and advocacy conferences. How can we discuss best practices specifically among OBGYNs? And we also did some social media and communication development that, to address some of these efforts. We also finally presented at the American Public Health Association in 2017 in Atlanta to again talk to others about some of the policy issues that we've been working on. We know the importance of the collective impact, and so several of you in this audience are doing things in the community and the hospital-based level, and we want to hear about those. Some of the next steps to think about include increasing role of the community partnerships and things that you're doing, again, at community-based organizational levels. How can we really address racism? So not only not being a racist, but really having intentional efforts at being an anti-racist in your hospital systems, your doctor's offices, your birth centers, your baby cafes, anywhere where patients are seeking care, focusing on those structural issues, personally mediated racist issues, and internalized racist issues that patients may experience. How can we use the best use of our outcome measures to really see what we're doing, and how can we improve that? So any other ideas, hopefully, and during the panel and before in the chat, you can start to type in your questions, because we really want to hear from you what other ideas can be done, or what best practices you have done in your communities. So hopefully I've kept on time, and I'll open up the floor at this time for any other questions. So thank you so much for the opportunity to speak to you.
Most definitely. Thank you, Dr. Claire, for an excellent presentation. And at this point, I would like to invite all of our attendees to start writing your questions in the chat box or the Q&A box, or both, whichever pleases you. And I also would like to introduce Paula and Patty, because we want to start our panel discussion. So let me just tell you a little bit about them. Patricia Soriano Guzman is an international board certified lactation consultant at the Prenatal Center at Montefiore Nyack Hospital, in charge of lactation services in English and Spanish. Patricia spearheaded the Prenatal Center's achievement as the first obstetrics practice to receive New York State DOH breastfeeding friendly designation in Rockland County as of January 2018. Patricia is also a certified perinatal mental health professional with advanced training for assessment of perinatal mood and anxiety disorders during pregnancy and postpartum. She plans and facilitates Montefiore Nyack's New Mom Circle support group, offering community families free parenting support, education, and resources. She has supported community families since 2013 as an accredited leader for La Leche League of Rockland County, and is the recipient of the 2020 It Takes a Community Award by Child Care Resources of Rockland. Patricia is a Bronx, New York native, first-generation Dominican American, and most importantly, a proud mother of 3 young children. Paula has worked as an advocate for breastfeeding mothers in Rockland County, New York for over 20 years. First as a La Leche League leader and week breastfeeding counselor, Paula became an international board certified lactation consultant in 2001. Employed as an IBCLC at Nyack Hospital, Montefiore Hospital, nearly 15 years, Paula has been educating staff and supporting mothers to reach their breastfeeding goals. In 2018, Paula was part of the team that received the IBCLC Care Award, recognizing lactation consultants working in hospital-based lactation programs. At Montefiore Nyack, Paula has participated in various projects aimed to increase exclusive breastfeeding rates, including the New York State Breastfeeding Quality Improvement Collaborative, a selective pilot project of 12 hospitals statewide to promote and facilitate system-level changes to maternity care practices that best support breastfeeding. This collaborative was the precursor to both the Breastfeeding'S New York and the current Creating Breastfeeding Friendly Communities initiatives. As a member of the Montefiore Nyack team that took on a subcontractor role in the first year of the Creating Breastfeeding Friendly Communities grant project, Paula helped to recruit healthcare providers to reach their breastfeeding friendly designation, and for Montefiore Nyack Hospital to become a breastfeeding friendly workplace. Most recently, Paula was instrumental in onboarding the utilization of pasteurized donor human milk for medically necessary supplementation at infants at Montefiore Nyack. So with that, and my God, we have terrific speakers. This is amazing that you are all with us today. We're gonna open for questions, and we have our first question coming. So do you have any ideas how we can draw more Black and Hispanic women to become IBCLCs? Are there scholarships available that you know of? Seems like there is very little diversity among IBCLCs. Very good question.
I can say that the New York Statewide Breastfeeding Coalition, of which I am a member as a representing ACOG District 2, we do have provided scholarships to Black and Hispanic women who, or anyone who wanted to receive an IBCLC. So I would say to go online at the New York Statewide Breastfeeding Coalition to look at those opportunities. I know one of my colleagues is at this presentation, and Stephanie did write that in the chat. So I would say that that's one of the places that you can start in terms of finding some scholarship support to become a IBCLC. I will talk to my colleagues offline because I said I keep wanting to do my IBCLC and I need encouragement. So I will talk to my colleagues after.
Great. And yes, I see Stephanie Sosnowski, if I'm saying it correctly, it says the New York Statewide Breastfeeding Coalition will offer another scholarship, and the next application will be available soon for next year. So that's great information. What approaches have you found effective in initiating a conversation with a first-time mom about breastfeeding so that she feels supported and thus more likely to breastfeed?
I can take that question. At the prenatal center, we do a fair amount of breastfeeding education every day, mostly one-to-one with our patients. And in my practice, my approach is really to start with mom, her current feelings about breastfeeding, you know, what her environment is like, her home environment, her circle of family and friends, what exposure she may or may not have had. So it's really about meeting mom where she is and her specific set of concerns and going from there.
Okay, great. Also, I have another question. I'm also a certified lactation counselor, and when I was working with African Americans, I always came across, or I often came across, to African Americans saying that they were afraid of choking their babies due to their breast size. Is that like common? Is that cultural? Like, how do we approach that?
I think there are so many myths and misconceptions culturally that are specific to African American mothers. I have not had an African American mother convey that particular concern to me, but there have been others that in the course of the conversation, when I'm doing just an initial assessment and starting off education, it is so clear that whatever the myth and misconception is comes from that generational trauma, whether they know it or not. So it may be breast size, it may be, like the presentation noted, oh, breastfeeding is nasty, why would I want to do that? It can hurt my baby, it's not healthy. Or, you know, maybe concern about diet, you know, unusual concern about diet. So anecdotally, there are many concerns. And as a woman of color and having a sensitivity to that perspective to a certain extent, what I try to do and I approach it is first with just acknowledging, being gentle and respectful in my approach, you know, receiving the information from mom and then explaining and giving the facts. what is research-based, evidence-based, and informing mom and empowering her in that way, no matter what the concern is. But I do acknowledge that in my practice, when I deal with women of color and particularly African-American women, the concerns are very unique and specific. And it has to be dealt with sensitively.
Okay.
Yeah, I just wanted to add one thing. I agree with having that cultural humility, that if you don't know what those myths and concerns are coming from, it's good to really, center the patient's voices on hearing what those concerns are, so that you're really able to provide that, that culturally sensitive information in a way that respects the patient. So I agree with what Patty was saying 100% with that.
Mm-hmm. Okay, we're getting another question. Can you speak to a specific community education or awareness programs or campaigns or practices that have been shown to be effective in increasing breastfeeding rates?
Well, I think that we work in conjunction with the Breastfeeding Friendly Communities initiatives and the grant that Department of Health and local community support is given. We give every patient delivering at the hospital, we give them a full resource of where they can get assistance after that will continue to offer some support with their breastfeeding and exclusive breastfeeding, hopefully for a longer time. They include the local baby cafe that was running in 2 different locations. They're now running in a Zoom virtual format, as most of us are with these things. And also Patty runs the New Mom Circle, which is a great group that she really started and she leads. So I think that directing them, whether it's to La Leche League or other support resources, especially locally, really helps out. And I think the Nyack Hospital, Montefiore Nyack's designation as a breastfeeding friendly workplace helps to get mothers back to work, offering and helping them obtain breast pumps so that they're able to return to work. I find that that is often a barrier for why mothers don't want to start breastfeeding. They think they can only breastfeed for a short period of time. So there are socioeconomic concerns related to their employment. How will they be able to do this in a few short weeks when they have to return to work? So those are some of the things that we do in our hospital-based programs in conjunction with community support efforts that really try to help support mothers ongoing.
And in addition to that, at the prenatal center, as being the first OB to be breastfeeding friendly, designated through the New York State Department of Health, we followed the 10 steps to being breastfeeding friendly in our office environment. So that means awareness and training of all staff, that they be ready and welcome to share resources or let patients know what services we have available in terms of lactation services and resources on hand. Having a breastfeeding friendly environment, a lot of graphics and portraits and beautiful canvases depicting breastfeeding, and having all of the information readily available through the breastfeeding grants, we were able to continue our breastfeeding nook, just a private area where all patients are welcome to come in, have breastfeeding education, conversation, access to resources for free, and just overall make it just normalized, a normal thing that's part of your pregnancy experience and your birthing and postpartum experience. The lactation and maybe not breastfeeding, but lactation is going to happen. So a mother should be informed and educated on the changes that will be occurring with her body, and how to best manage it.
Excellent. And, you know, I'm going to read this question just because it's online with what I was just thinking. Prenatal education seems to be so important for breastfeeding initiation and duration rates, and the data presented here supports this. What could be done to increase access to education? Should we be focusing on tailoring this to specific subsets of our population who are at risk for breastfeeding issues. And I would like to add something that got my attention is how there is an age disparity as well. And, you know, like girls or moms with like high school diploma breastfeed less. So I was thinking, you know, we teach so many things in a school about health. We have health class and all of these. Is breastfeeding ever part of that health class?
I would say, in addition to what my colleagues have mentioned, what we've done at our hospital, which is also a baby-friendly designated hospital, we've used the support of peers. So we've used other moms who've been successful in their breastfeeding journey as individual peers, which has been very, very helpful. Obviously, pre-COVID, when we were able to do that even more, but how can we do those efforts a little bit more to increase peer support? So moms hearing from other moms who were successful or challenges, that has been really, really helpful for us in being able to encourage that initiation and continuation of breastfeeding in our setting. Also, there's a business case for breastfeeding that the state supports, so that moms that are returning to work and may have any challenges in terms of where she's working can seek some help. Again, the New York Statewide Breastfeeding Coalition has a lot of resources on their website that they can take a look at. Stephanie also put a bunch of information in the chat for others as well to help people who are having issues when they return to work as well.
Yes, absolutely. That was part of the conversation, I think, early on too, as we were preparing, is having an eye towards teenagers, teens, young women, young adults, and their unique and specific set of concerns and barriers to breastfeeding, and having resources specific to that. Resources specific to the African American community for breastfeeding do exist. We have some beautiful graphics available to us at the prenatal center that we love to distribute. And even just generally, the general education should be diverse, should be representative of all mothers and all circumstances, and starting there. But certainly, I think there is a need and a call, and we'll start seeing more targeted resources for the African American community specifically. Some already do exist for teens, and just more and more tailoring the information that we're giving to the person for their unique set of circumstances.
Yeah, and my feeling is this is something that has to start prenatally as well, right? Like we can't wait for moms to deliver their babies and start the education at bedside in the maternity unit. This has to be part of all that prenatal care as well. Like they have to be mentally ready when they have their babies. Dr. Claire, were you gonna say something?
I think I was going to say just using the effectiveness of social media. I think we may not use that as strongly as we probably can going forward, especially for that particular group that may be on social media as a platform to really get some of our message across. Stephanie also mentioned in the chat, you know, prenatal efforts, so centering pregnancy or prenatal care has really been helpful. So in a group setting, moms can learn from each other, especially about things such as breastfeeding. So I think we just have to be a little bit more creative in these models to address these specific groups that we're thinking about.
Absolutely.
Yes. Yeah, I love centering pregnancy. This is something that I used to do for many years, so I can attest of the efficiency and efficacy of that. So as women are coloring your careers, what are some barriers or challenges you've experienced working in this field? And what is one way you've worked through those challenges?
Can you repeat that first part, Sandra? I'm sorry.
As a woman of color, what challenges have you encountered in your career working in the field, and how have you overcome the challenges?
I guess that's me. I would say specifically as a Black woman physician, microaggressions are real for sure. I mean, I think We're looking really at the medical school level, at the hospital system level. How can we really intentionally be anti-racist in our approach to curriculum? Looking at improving the workforce, the physician workforce, which I've had at the center of my career to increase the number of students and residents and fellows who are in my specialty as well as in medicine, has really been helpful for me to overcome some of those challenges, and also really working as part of a healthcare team. Obviously, as an OBGYN and addressing a lot of the issues with maternal mortality, especially now, we're working with my colleagues, such as the midwifery colleagues that I work with, the doulas that I work with, really has been able to help me, continue that team-based approach to the care, as well as my lactation colleagues that I'm talking to now. So I really appreciate the opportunity.
And I'd like to also, thank you, Dr. Claire. I would like to also speak to that. I think personally, as I reflect on my personal experience, my experience was different. It was very atypical, not necessarily one of having barriers. I came to lactation specialty through my experience as a mother, through La Leche League participation and ultimately training, and did my pathway through IBCLC. By the way, IBCLC also offers scholarships for anyone who's looking into that and interested. And I have to say, I feel very fortunate and grateful that in my personal experience with the birthing educators, the specialists, and the support that I sought out, I didn't necessarily experience the barriers that we're discussing today. And I came to learn about it through my path as a lactation specialist. That being said, as a woman of color, I feel a responsibility and accountability to this cause and to this movement, and to be able to inform, educate, and inform mothers, and empower mothers, really, to self-advocate, because that's really what it takes. And looking back and reflecting, I think what might have been different was really that I really wasn't aware of barriers and challenges. All I knew is that I was a new mother, and I really wanted to breastfeed, and I really wanted a natural birth, and I wanted all these things. And so sought out the information. And when I didn't feel heard, because nothing is perfect, and we all have our issues and challenges, when I was not felt heard, I wasn't afraid to make a change. And that is so critical to mothers. And I'm speaking more to the community now, as opposed to the professionals, and even the professionals, to really listen. You know, at the hospital, we have the program, What Matters to You Most? And to be able to ask that question and hear each individual person as to what their specific concerns and needs are. And in doing so, then we'll be able to hear. And I encourage mothers that I do education with and that I support to advocate for themselves. Even when you don't know what you're looking for, or what may be useful to know, just ask why or how. And there you'll start drawing out the information that you need to make your experience a success.
Mm-hmm. Okay, so we're running out of time. We're gonna do just one more question. Is there any organization that we can plug into that is advocating for paid maternity leave? I find that having to go back to work is a major challenge moms face that prevents them from establishing breastfeeding. That's a question we're getting from one of our attendees.
So is the question how to help advocate for paid maternity leave? Is that the question? Oh, so I think many different groups have started that. So again, Stephanie writes in the chat, the New York State Paid Family Leave Coalition is one. We've done work again on the New York Statewide Breastfeeding Coalition is another. I think ACOG, the American College of Obstetricians and Gynecologists in New York State or District 2 has some resources as well. So I think there's several different groups that are working on that. I'd be happy to speak to people afterwards to help them with their advocacy or what their concerns would be. So I think that's a start for sure. Another person just had a quick question in the chat just about how to initiate these kind of conversations regarding these cultural taboos and intergenerational issues. So I would say just really leaving a space open for patients, as Patricia mentioned, to share their own experiences and where they're coming from. I think that's a really good place to kind of start the conversation. So I just wanted to make sure I got that question answered for that participant.
Yeah, in my own experience, I think, motivational interviewing helps. It's just asking the person where they are at, and obviously being very, very respectful of their position at the moment, and then just sharing information is the best. It's not lecturing anybody, not telling them what the best is, but just asking for permission. Can I share some information with you that might be useful, and letting them always take the lead in what they want to learn, and and when they want to learn, and if they want to practice it. I think that as lactation counselors, we can only hope, we can only provide the information, but we cannot make anybody change their minds around breastfeeding. So thank you so much to all of you. It's been great to have this chat, and we're gonna be having more chats on breastfeeding and more webinars. So all of our attendees today, you were great. Thank you for sending all of your questions. The chat is not stopping. I see people, it keeps moving, which is very nice. And it has resources in there as well. You have our contact information, so if you wanna just create like a network to work together, that will be terrific. And it's 101, so we have to go. I wanna be respectful of everybody's time. Thank you again. Goodbye.
Thank you.